Amy Jo Cook and Dan Hall are the community paramedics in Clackamas County. They formed a partnership between American Medical Response and Clackamas Fire to fill the gaps in today's healthcare delivery system. They do frequent community assessments to see where the greatest needs are and how they can help. The most recent focus is on the opioid epidemic. And they formed a partnership with Clackamas County Public Health to better serve the needs of people with substance use disorder after they overdose. And their current work is called Project Hope. Please give a warm welcome to Amy Jo Cook and Dan Hall.
Thanks, you guys. Before we even get started, I want to thank the former presenter for talking about the fail first. We've had so many patients that we're working to get into programs, and we want insurance help and all this other kind of stuff. They're like, well, they don't qualify. They have to fail first. And I don't get that at all. Part of failing first means 911 is activated. And we're not always successful in the resuscitation. There's not always that second try. So when you give people well, they have to fail before we're going to help them with medication to get through this. No other provider would say that about coronary artery disease. No other provider would say, like, you need to have one more asthma attack before we give you an inhaler. So just once you have that, then come see me. So anyway, before we even get started with our part of the presentation, I just want to thank you for calling out the fail first because it's ridiculous. All right, on that note, sorry, I have many soapboxes, and that's one of them. Okay, so you've seen a couple of these slides, and, let's just talk about why I'm even here. There's a serious opioid epidemic. There's a huge gap between when people have an overdose and when they can actually get care. There's this lapse in time where people are super susceptible to going back on their drug and having a fatal overdose. So you've already seen these slides before. It talks about the definite need for some sort of intervention in the field. Both these slides talk about where we get our information and why we're here. This is just OD map surveillance for Clackamas County. This information comes from first responders, police, fire, EMS. When we go out on an overdose, we are able to click on this map, and this gives us the ability to kind of triangulate where a surge in overdoses are and where we can concentrate some of our resources to try to help navigate through this system. So let's go to why we're here. Traditionally in the fire service, we respond to 911 calls. Dan and I have been responding to 911 calls for the better part of 20 years. When somebody overdoses on an opioid, they traditionally stop breathing. Somebody calls 911, fire engine shows up, ambulance shows up, we give supportive care, we give Narcan, we hopefully get the person breathing again, we put them on a gurney, we send them to the hospital. Once they get to the hospital, they're maybe treated, maybe they get out of the ambulance, walk out of the ER. We're bringing them in a state where they're very most vulnerable. So whether or not they even get help, when they get discharged, they're discharged with paperwork that says, hey, go see your primary care physician in 7 to 10 days, and don't do heroin. And if you think I'm kidding, I'm not. One of the patients we went to go help, I go, can I see your discharge papers? And that's exactly what it said. Follow up with your primary care physician in 7 to 10 days. Stay away from heroin. I'm like, oh, that's super helpful. Thanks for that, because I didn't know that because I just died from heroin. So I think that there's a huge lapse in how we treat overdose patients to begin with. If I sprain my ankle, when I leave the emergency department, I have 4 pages of how to treat my sprained ankle. I have a referral to an orthopedic surgeon. I have a referral to physical therapy and all these other resources that will help my sprained ankle. If I overdose, hey, don't do heroin. See ya. Good luck with that. So we're releasing these patients in not only their most vulnerable mental state, they feel shame, they feel alone, they feel like they just died because they did, and then we have taken away their high. So now their physical state, we've released them, and they're completely in withdrawal. So all their mind wants to do is fix the withdrawal and find the drug. You mentioned earlier, it's not about the euphoria of getting high. Now it's about, I don't want to feel this bad. And that's how these people are going out into the community. Unfortunately, what happens is they take the drug again, 911 is activated, Dan and I show up, we give supportive care, we give Narcan, we send them to the hospital, they leave the hospital, they overdose, they call 911. It's kind of a lather, rinse, repeat kind of cycle. And unfortunately, a lot of the ways that that cycle is broken is when it's a fatal overdose. Dan and I have both experienced that on, unfortunately, more than one occasion, where the next time we show up, there's nothing that we can do. So what's Clackamas County do for that? We have community paramedics. It's a program where we kind of pick up where 911 leaves off. And we do assessments to find out where we're needed the most. Currently, we have a program with public health where we can do opioid overdose treatments, where we don't actually do the treatment, but we bridge that gap between being released from the emergency department after an overdose and getting to the care that they need. It's kind of a, like it says up there, it's a resuscitate then navigate kind of system, where we have a more patient-centered, recovery-centered wraparound care for the patient. We're able to go out in the community, hopefully within 24 to 48 hours of the overdose, and interact with the patient and help them figure out where to go from here. They're in a place where they're completely alone, and now we reach down and we offer them a little hand of hope. I had a speaker say to me one time, I guess he said it to the whole group because it was a conference, but I took it very personal. He said, "Where there's breath, there is life." And that had such an impact on me because he's right. If we can get this person resuscitated, there's a chance. And so I joked with Dan and I called us, I go, you know what? We can bring this into community paramedicine and we can be ambassadors of hope. And that was kind of the joke that I called us. I call us ambassadors of hope. And so when we had the opportunity to partner with public health, it seemed like the natural formation of our name. Instead of calling it the pilot project, we just started to call it Project Hope. And that's where this project started.
So when we go out and we're out running around, Amy drives because I drive ambulances, and we don't work in an ambulance anymore. But it gives me an opportunity to scroll through my Facebook feed, which is my addiction. And yesterday when I was scrolling through, I saw it made me chuckle. I saw a post that somebody put up. It was a sign that somebody had put up in their establishment at a fast food restaurant that said, "You're only allowed one overdose, and after that, you're banned from this facility forever." It's a tough crowd. So it kind of, it lets you know kind of where we are and why we're here, right? You only get one overdose. After that, you're done. So, as Amy was saying, we go to the bathroom in that facility. We take care of the person that isn't breathing. We give them some Narcan. We do some airway support. And we ship them off to the hospital, where they get the discharge papers that says stay away from heroin. So for us, this is the exciting part, where we get to go contact that person who is neurologically intact because we gave them Narcan, we did airway support, we got them to the emergency department where they got stabilized. So there's a chance, right? So we come in, we contact them, we just go knock on their door. And at first, generally the reaction from them is, "Oh no, somebody's here to rake me over the coals because I had an overdose."
I am not a cop.
And we called 911.
It's the first thing I say.
Yeah, she'll push me out of the way and move in and shake the person's hand and say, "I'm not a cop," right? So once they understand that we're not there in a punitive manner, we're there to actually offer some help and some hope. Generally, people are very, very inviting. And I think 9 times out of 10, people want the help. They don't know what to do. They don't know how to get out of the situation they're in. And so we're able to come in, bring in some resources, offer them some sort of a direction to get them out of that circle and break that cycle. So we'll offer them treatment. What does that look like? Everybody's different, right? So what do you want to do? You want to do methadone? You want to do Suboxone? How does that look if they don't have a healthcare provider? We'll get them connected with a healthcare provider with that treatment in mind. Housing can be an issue, so we'll get people connected with housing resources. Transportation, that can be an issue, so we try to provide a way for them to get to appointments and to get to their treatment, whatever that may be. We have a guy that's inpatient. Well, you saw him on the screen. He's an inpatient right now, and he's been clean for what, 4 months? 4 months. He wanted to do methadone, so he's working through the methadone treatment. So, you know, there's a good example of, you know, what we do right there with Jackie. And, you know, Jackie, not everybody's like Jackie. We've knocked on the door and people say, oh, I'm fine. I'm good right now. And then a month later, we'll get a report saying, well, they've had another overdose. So that was the other thing I was supposed to talk about, is how do we meet these people? How do we find these people, right? So whenever there's an overdose in the county, we get a report, and we can then dig into that chart and see if they meet the guidelines for our program. And if we do, then they go on our stack, they go on our spreadsheet, and we go out and meet with those people. So that's how we find who those people are that we need to go see, is through administration of Narcan. The other thing we do is we'll give them a Narcan kit, and we'll show them how to use it, and we'll give them some education on Narcan, not only for themselves, but maybe for their buddy, right? So again, where there's breath, there's hope. And that's really what we're all about in this project.
I'm glad to see so many behavioral health providers here, because one of the things that we also bring to our project is peer support. Dan and I go out and make the first initial contact, get some buy-in, find out that they want some help, and then the subsequent visits, we have behavioral health come out with us, and we have peer supporters that have lived experience and can really understand what the person's going through and help them understand what to expect, having never had an addiction issue other than, you know, like Facebook and, you know, lattes and stuff. I'm probably not the best person to help, you know, really identify with the patients, but I am the best person to connect them to the resources that are available. We've heard earlier, there are a lot of resources, for sure. The people that need them and the resources available might not always equal out, but they are out there. And getting the people connected, bridging that gap, is what Dan and I do really, really well. So we bring in the people that can help us be supportive all the way around. We bring in primary care physicians that specialize or that have taken on medication-assisted treatments. We bring in peer support. We bring in housing specialists, insurance people, anything that people need, we help them find. That's what we're good at. That's what we do. And then we can support them medically if they need anything else. And that's what makes our program, I think, a little bit more successful than some of the other programs. The cool thing about our program is that you can replicate this program anywhere in the nation. This is easy to do. You have to have people that want to do it, and you have to have departments and districts that will support this kind of work. The goals of our program are simple. We want to reduce the number of overdoses that are repetitious, and we want to reduce death. I mean, that's why we're all here. We're all here to help people. And in general, the bottom line for our program is we don't want people to die from doing opioids. We want to help combat the opioid epidemic on the street level and get them connected to the resources that are out there. We had at the same conference that Dan and I were at, we had a speaker that talked about funding, and he was Senator Hal Rogers. He's a huge advocate for opioid use disorder and for programs that are going to be available for people. The cool thing about, well, goodish, about the epidemic that we have now, we've known it's always been there. Dan and I have been going on opioid overdoses for years. But now that it's reached national attention, comes national attention, which brings in national funding. And that's one of the good things that comes out of such a horrible epidemic. The senator said that a vision without funding is a hallucination. And I use that because on the goodish side of things that come from this is that hallucination is now becoming an actual vision. There are federal funds being put into this system to help combat the opioid epidemic, and that's where Project Hope comes in. We were a federal grant, and I just hope that that push keeps coming because, like Dan and I said, where there's breath, there's hope.
We got a couple questions. I'm running back.
Two quick comments and a question. I'll make it real brief. One, thank you for the amazing work that you're doing. As a result of your presentation, I'm now going to add belatedly EMS into that continuum slide, so thank you for that. Two, I would strongly encourage any payer in the room to support the work that you're doing with a payer-based analysis of the patients that you're touching to really understand the impact that you're having on the continuum and the lives of these patients as evidenced through not just the lives of the patients, that's the most important priority, but also how this is impacting outcome and spend through those optics. Lastly, what do the two of you and the work that you're doing need in the next 6 months? Not some federal funding round in the next 12 or 18 months, but what do you need more of in the next 6 months to impact this population that you're serving?
Sure. Funding is always something that we need, but honestly, I need buy-in from our patients. I need support from medically assisted treatment places, and I need somewhere to put the people. I need somewhere for them to go. It takes multiple times to get them into detox, and I get it. There's a lot of people that need detox. I've gone in there with a few of my patients and then left, and I'm like, dude, get through the next few hours. I'll pick you up in the morning. We'll do this again. I bring them in again 3 times. Okay, great, you're in. So they get through detox, the roughest thing I can imagine somebody going through, and then there's no handoff. They're like, okay, they say I'm done. And I call around and there's no beds. So somewhere where we could take somebody from detox to something that's supported would be probably my biggest goal, my biggest bonus to the program, because it's in that interim from detox to getting them into somewhere that is supported, whether it's supported housing, inpatient, outpatient, whatever. It's tough to get them in. And I think that's where Dan and I end up really making a difference, is that we're that one constant. We stay with them every day. Jackie, what do you need? I can't get you in yet. I'm working on it. I'm going to hook you up with a peer supporter. Let's get this going. And so we try to stay with them and be that support for them until I can get them into supported housing.
That was one of the questions that I had. I'm over here.
Oh. Like, where are you? There you are. Sorry.
So you struggle with access to different programs. Like once you're with them, do you struggle with where to send them, or knowing where to go, or getting access into programs? What's the actual knowing what the resources are, or there's no openings? What's the actual struggle? Do you know where all the programs are that they might be eligible for? Do you feel like you have a handle on what the resources are?
Yeah. Generally, it's that the beds are all taken, and places are full, so we're on a waiting list. And so, insurance is a good one, is a huge one too. Yep.
I was just gonna say, it sounds like there are some people who are interested in becoming MAT providers or learning about that, and that's why they're here. Maybe it would be helpful if all the behavioral health places or people who are MAT providers could like raise their hands so that people know who some resources are of where to send people and maybe who to come and talk to after the training is over. Would that be helpful for people?
Yeah, we brought
Absolutely.
some cards, and if you
Cool.
guys have a program or a resource, we are all about it. Just give us a contact, and I have more
Cool.
patients than I know what to do with most of the time. So
Yeah, so maybe if you guys, if anyone is a provider who does MAT, you want to raise your hands for everyone?
It doesn't matter. Cards right here. So if anyone wants to grab those and send us an email, that would be an incredible opportunity for us.
Excellent. Give these guys a huge round of applause, please. Unbelievable.